Hello, and welcome to this presentation on wearables for health, turning physiological signals into clinical insight. Now, you may have seen one of these signals, an ECG signal, perhaps when watching a hospital drama on TV, or if you've been unfortunate enough to be in intensive care, perhaps when being monitored there. And the eager-eyed amongst us may also have seen one of these signals. This is a photoplethysmography signal measured using a light sensor. Now, these signals are traditionally measured in hospital or clinical settings, but they can now be measured using consumer wearables, providing opportunity to monitor health at scale across the population. To introduce myself, my name's Peter Charlton. I'm a biomedical engineer and researcher. I started my working life here at St Thomas's Hospital, where I was tasked with taking the monitoring technology from the intensive care unit out to the wards in the form of wearables. Nowadays, with the rise in consumer wearables, I focus on monitoring in the field. And today, I will suggest that 3 questions hold the key to using wearable signals to inform clinical decision making. First, what information do wearable signals contain? Second, how can the information be extracted reliably? And third, how could the information inform clinical decisions? So first, what information do wearables contain? Let's go back to our ECG signal in green at the top and photoplethysmography PPG signal below. The first thing they can be used for is to measure heart rate, because the ECG contains a spike for each heartbeat and the PPG contains a peak. They can then be used to assess heart rhythm from the differences in interbeat intervals, how regular they are. Here is an example in atrial fibrillation, a common heart arrhythmia. Now, this is an example of how the signals could vary due to breathing, where you can see the changes in amplitude and baseline wonder with each breath. And if we look even more closely at the shape of individual heartbeats, then we can gain information on the heart's electrical activity in the ECG and the heart and blood vessels from the shape of the PPG pulse wave. We sought to understand what affects the shape of the PPG pulse wave, and to do so we used a computer model to simulate how blood flows around the larger arteries. I'll focus on the simulated PPG pulse waves acquired at the wrist, comparable to those measured using a smartwatch. And here we can see how the shape of this pulse wave varies relative to a baseline in black when we vary each of the properties in turn by plus or minus 1 standard deviation from the mean for a healthy subject. And you can see that if you are interested in, for instance, estimating blood pressure from this signal, then a key challenge is to extract the influence of blood pressure, whilst other factors may also influence the signal in similar ways. So, my message: physiological signals contain information about several aspects of physiology, which is potentially overlapping. It is now possible to measure these signals using consumer devices where they are altogether more noisy. So here we have an example with high quality signal and then low quality signal in the middle period. In this study, we examined just how clean or noisy the signals were, and I show 3 examples at the bottom, going from a noisy signal on the left to clean on the right. And then formally, we assessed how noisy they were in terms of the signal to noise ratio. And my message here is that signal quality varies greatly. And this is important because signal quality affects algorithm performance. So here we have the errors in heart rate derived from the PPG signal for noisy periods, shown in dark grey, and then clean signals shown in white. And you can see the errors are much larger for noisy signals. So how can we obtain high quality signals? Here we were looking at this for the wrist PPG, and we found something that I think is relatively new, that quality can vary with sensor height, and if you want high quality signals, ideally the sensor should be up at heart height rather than down by the side of your body. So my message: signal quality varies between subjects, device designs and recording conditions. Second, how can the information be extracted reliably? Or, to put it another way, what algorithm should I use? For much of my working life, I have been concerned in benchmarking algorithms. And here's an example. Say you want to detect individual heartbeats, individual pulse waves in the PPG, so that you can then do further analysis. We benchmarked algorithms for PPG beat detection across different use cases and between different patient groups. To do so, we created a toolbox of open source algorithms. We assembled a publicly available datasets containing both PPG signals and simultaneous ECG signals. And we created an evaluation framework to assess algorithm performance. We detected beats using 15 open source PPG beat detection algorithms. We compared those to reference beats from the ECG, and we quantified performance using the F1 score, which combines sensitivity, the proportion of heartbeats which are detected, and positive predictive value, the proportion of detections which are correct. This provides a wealth of results. Each panel corresponds to either a different dataset or a different activity within a dataset. For example, here we have performance when people are having their lunch break. The 15 beat detection algorithms along the y-axis vary in performance, as shown by different F1 scores on the y-axis, where 100 is best performance. So it matters which algorithm you choose. It also matters what conditions you measure the signals in. So here at rest in hospital data, 8 beat detectors performed well. But then if we move to data during exercise, going from left to right, the performance drops during exercise. And then if we compare performance between patient groups, we find, first, on the left, performance is poorer in atrial fibrillation. In the middle, performance is poorer in neonates than adults. And on the right, in this study, there was no difference in performance between black and white subjects after correction for multiple comparisons. We were able to conclude which 2 beat detectors perform best. And so my message: benchmarking studies help identify algorithms for use and understand their performance for particular use cases. Wearable signals present additional challenges. So we had our 2 best performing algorithms, but the issue was neither was perfect. One was available under a more permissive license, whereas the other wasn't, and the other was highly efficient, whereas the first was less efficient. So we then optimized the first algorithm to improve its efficiency, and we make this openly available. So my message: we may need to optimize algorithms for real-world deployment. Finally, how can the information inform clinical decisions? It's thought that if atrial fibrillation, the most common heart arrhythmia, was adequately diagnosed and treated in England, then this would save 2,000 lives per year, it would prevent 7,000 strokes, and it would result in an additional 425,000 diagnoses. And here, it's important to note atrial fibrillation is often not recognised in routine practice because it can occur without symptoms and infrequently. If we compare our normal ECG signal to one recorded during atrial fibrillation, then we can see that one can identify atrial fibrillation from the irregular beat-to-beat intervals and the absence of P waves in the ECG. So we have a method for identifying it using ECGs, and fortunately we can now acquire ECGs using a wearable. But what we don't know is how reliable diagnoses from a single lead ECG are. So we know from a traditional 12 lead ECGs diagnoses are highly reliable. Only 3 in 1,000 do cardiologists disagree on the interpretation. We used single lead ECGs measured in a AF screening research program conducted here in Cambridge to try and find out how reliable the diagnoses were. Participants recorded 4 30-second ECGs per day for a period of 1 to 4 weeks. Each ECG was automatically analysed using an algorithm, and then those that showed signs of possible AF were sent for clinical review. And we compared diagnoses on those ECGs and participants which 2 cardiologists reviewed independently. So 1,800 ECGs and 190 participants. First, we found that agreement between cardiologists was moderate, both on ECG level and participant level diagnoses. Second, agreement was lower on low quality ECGs, and these really are the lowest quality ones. And indeed, retrospectively, we see that if these had been excluded from review, then we would have reduced the proportion sent for review while still maintaining the correct identification of all the AF participants. So potentially you could exclude low quality ECGs from review and more generally use high quality measurements for clinical decision making. Agreement was higher on ECGs showing algorithm identified possible AF. And again, we find that we could have excluded these from review and we would have still identified all those participants with AF. So, in screening, one can use a sensitive algorithm to identify possible AF and send those ECGs for review. And more generally, we could use algorithms to identify signals which can be reliably diagnosed. Fourth, agreement was higher amongst participants who recorded more than 66 adequate quality ECGs. In AF screening, we should therefore ensure sufficient adequate quality ECGs, and more generally, we can use repeated measurements to increase reliability. Our main finding: for every 100 screening participants diagnosed with AF by 2 cardiologists, there would be complete disagreement over the diagnosis of 70 further participants. My message: specific approaches may be required to incorporate wearable data into clinical decision making. So to conclude, I will refer back to our 3 questions and answer by saying information about several aspects of physiology is contained within wearable signals, and this information can potentially be overlapping. Signal quality varies between subjects, device designs, and recording conditions. We can benchmark algorithms to identify the best across different use cases, noting that wearable signals present additional challenges. Algorithms may need to be optimized for real-world deployment, and we need to handle noise appropriately. And finally, clinical decisions should be based on high-quality measurements. We can use repeated measurements to increase reliability. We should identify recordings likely to lead to accurate diagnosis and tailor pathways to the clinical goal. Thanks for listening.